Everyone knows paracetamol is a medicine being available over the counter and being used by the small populations of this pediatric population basically. It's the most common drug taken in overdose form because it is available in syrup as well as in candy form. So the men 6 years of age group, they have a tendency of putting everything into the mouth, and subsequently they land off in overdoses and toxic doses of paracetamol particularly. Few symptoms, early conditions, it is very mild to moderate. So many of the times the symptoms is not accurate. They are basically vague symptoms, and we may ignore the early signs of this poisoning. So basically, in the presentations, I'll be talking about neglect this initial part of overdoses of this paracetamol. That includes nausea, vomiting, and many of the times it is a small age group, what I have already shared, that is affected. So they don't communicate properly. So that is what we may face a very real challenge in dealing all these small populations age group. And coming to this, like as little as 12 gram of paracetamol overdose, it can be fatal sometimes because there's three kind of things. One is toxic dose, one is fatal dose, subsequent slides. So coming to this pharmaceutical classes of acetaminophen is classified under the derivative properties. It is having three properties. One is analgesic, another one is antipyretic, another one is anti-inflammatory. This paracetamol is safest in all kind of conditions except liver failure. So suppose someone is pregnant and he's having some kind of body ache, muscle pain, or something like that. So doctors used to advise take a paracetamol and you will be all right. So it happens. Like this is the drugs is commonly available over the counter, and it is very cheap also. So coming to the characteristics of acetaminophen, soluble in cold water, greater solubility in hot water, and many of the times it is soluble in the menthol form. So coming to this mechanism part, particularly, there are three kinds of three way of paracetamol mechanism is by liver by three method. One is glucuronidase and sulfations. It constitutes almost 90% of total mechanisms, resulting into non-toxic products. And another 5 to 10% that happens by N hydroxylation and rearrangement, that is cytochrome P450 cytochrome inhibitors. So that's resulting into toxic form that is called NAPKI, N acetyl forms. Okay. Broadly classified into the secretions like almost 2% around that excreted through urine. Okay, and what I said, majority of the conditions like 90% of the time it is by the glucuronidations and sulfations method, resulting into glucuronide and sulfate metabolites, that is a non-toxic form, and P450 resulting into NAPKI. NAPKI, that is a toxic metabolites that really plays a great role in management of acetaminophen. So as I said, there is a phase one reactions that is oxidized by the hepatic cytochrome P450, and second route that is phase two reactions. It happens because with the conjugations with sulfate and glucuronide to form non-toxic metabolites in the liver. Now coming to this NAPKI. NAPKI is a very important factor, as I said. It is a toxic byproduct of acetaminophen poisoning. It is detoxified by conjugations with glutathione. Okay, this glutathione that synthesis occurs in liver only, and resulting into mercaptonic uric acids that is harmless and clean. So this graph is should not forget about this graph that is called Rumack-Matthew nomogram. Whenever there's a paracetamol overdose or toxic dose patients presented to us in emergency, so we need to calculate the hours post injections, and depending upon the serum paracetamol concentration value, we need to put a line along with this. So we need to check the units of paracetamol very thoroughly, because many of the times it is written as milligram per liter. Many of the times it is written as micromole per liter or neomole per graphical presentations. Coming to the clinical history, this clinical course of paracetaminophene toxicity generally is divided into four phases. That is class 1, class 2, class 3, and class 4. The physical findings, many of the times it is vary. It is very vague symptoms depending of symptoms to leading to the hepatotoxicity, and ultimately patient need liver transplant for the ultimate poisoning. This clinical categorized into four stages. As I said, in early stage, it is maybe asymptomatic or have anorexia, nausea, vomiting, or some small mild abdominal pain. But we should not underestimate this condition. The second stage, that is called latent stage, patients may be or may not be having any clinical symptoms. Clinical signs you will have, but we need to take care of this early stages. If we'll fail to do this, here worsening of liver injuries occurs. Such as abdominal pain, nausea, vomiting, and many of the times bilirubin will be very high. They will be having icterus all around his face. There will be oliguria, and ultimately patient will die. If by chance the patient survives, that is called stage 4, that is called recovery stage. Eventually, gradually that improves and overall patient outcome is better. So make sure we need to take care of stage 1 and stage 2 very early, and we need to depend upon some clinical investigations, and we need to rapidly thorough with the clinical signs and symptoms and investigations, so that we can prevent this stage 3 and stage 4. Up to 24 hours after the injections, and patients may be asymptomatic in early phases and reports like times. The physical examinations will may reveal pallor, diaphoresis, profuse sweating, malaise, and fatigue. But if we'll fail to examine the patient thoroughly, or you underestimate this kind of symptoms, or you ignore it, then the patient will land up into phase 2 or phase 3. That may take 2 days till 3 to 4 hours, 3 to 4 days. Patients generally develop right upper quadrant pain. That is a classical sign. Whenever you are having a paracetamol overdose patients presented to you after 2 days or 3 days, you can see, you can touch the patient, they'll say I'm having pain over the right abdominal pain, right upper quadrant. Patient will having nausea, profuse vomiting, and there will be tenderness over the right upper quadrant. And many of the times patient will end up into tachycardia and hypotensions, indicating ongoing volume losses. We need to replace with the IV fluids, crystalloids, and we need to do it very thoroughly, because if we'll fail to examine or fail to address these issues, then the patient will land up into phase 3 and phase 4. So the phase 3 is the very disastrous conditions. Here it occurs after 3 days. It nausea, vomiting, abdominal pain, and tenderness over the hepatic edge. Here, what happens basically, hepatic complaint, coagulation profile, the patient will end up into hypoglycemia and hepatic encephalopathy. This hepatic encephalopathy really a very challenging factor for the clinicians to deal. And here, the LFT reports like the enzymes, liver enzymes, the LT, AST level will be very high. Of paracetamol overdose poisoning cases, and death usually occurs because of multi-organ failure. It involves your kidney, it involves your lung, it involves your liver, many other things. So once the patient is lucky enough to survive the third phase, that comes next is recovery phase. It occurs after 4 days to 3 weeks after the injections. Patients who survive critically down of the declining phase of all the liver enzymes like ALT, AST, and the everything, and complete digestion of the organ failure. So, what are the consequences of severe toxicity? As I mentioned in my previous slides, hepatic encephalopathy is a main challenging factor because here the so we need to take care of very seriously when you are dealing with this paracetamol overdose cases. Next come is glutathione, as I mentioned, which is the most important antioxidants present in the liver, and it is the only site where glutathione synthesis occurs. So liver is the only place where glutathione synthesis occurs, and it is the most important antioxidants in the liver. So now coming to the toxic doses of paracetamol, it is not a bottom line, like it is also there having a wide range of doses. We need to remember few things here. So if somebody has ingested in a single injections at a time, the toxic dose will be more than 7 to 10 gram, that is 150 mg per kg in case of pediatric populations. The fertile doses usually involve doses at least 15 to 25 grams. This is a fertile dose, and what I was talking about is toxic dose is around 7 to 10 gram. In heavy drinkers or alcoholics, the daily doses is from 2 to 6 gram have been associated with the fatal hepatotoxicity. So for the alcoholics, the dose is very low. It is around 6 grams. And coming to the plasma half-life of paracetamol, it is 2 to 4 hours. So that where the first phase of clinical symptoms occurs. Coming to more details of signs and symptoms, most patients who have taken an overdoses of acetaminophen will initially be asymptomatic, as I said. And as a clinicians, we need to take care of all these, because if we will not treat in a timely manner, the patient will end up into phase 2 or phase 3 that will occur after 24 to 48 hours of injections. The minimum toxic doses for a single injections posing significant risk of severe hepatotoxicity is for the adults it is around 7 to 10 grams, and for children it is 150 to 150 mg per kg. For the healthy individuals, like the healthy babies, we may encounter up to 200 mg per kg body weight. So coming to the investigations part, what are the investigations basically we do in emergency settings? We need to take care of this blood glucose level. We need to take care of blood and urine toxicology screening and serum paracetamol level. But this report will take time to come, but you need to take care of the clinic, you need to manage the patient by looking at the clinical signs and symptoms. We should not forget to send the renal panel 1, that is RFT, LFT, the ABG, and the coagulation profile, including your PTINR and APTT. Most important factor affecting the mortality are the time of presentations. If someone is presented to you after 12 hours or after 1 day of paracetamol injections, then in those cases, it will be very difficult or challenging factor to treat them, because the mechanism here is the cysteine that thing within 12 hours abolishes the significant liver injury. So the clinicians will have a challenging factor in dealing with the patients, those who are latecomers to the emergency department. So other prognostic factors includes age, extreme of ages. It is very difficult, challenging for the clinicians to treat. Second one is alcohol. Third is malnutrition, and fourth is a fasting conditions. Prolonged fasting conditions means more than 8 hours of fasting. Coming to the age, children have faster turnover time of glutathione or increased sulfate conjugations. Hence, they might be less likely to get hepatotoxicity, but decreased glucuronidation capacity is there. So it is very difficult to treat in case of a pediatric populations. Coming to the alcohol, the alcoholics that induces the cytochrome P450. So chronic alcoholics, the toxic dose is low. As I said, it is around after 2 to as low as 2 grams till 6 grams. Next one is malnutrition. Malnutrition, what happens here is it decreases the glutathione reserves. So ultimately, patient will suffer a lot when you are like unable to deal in a proper manner. Next one is fasting. The fasting patients are high risk of, because since 4 gram to 10 gram can easily induce the hepatotoxicity. So what are the indicators of a poor outcome? That it's very important to understand when there is a patient who has ingested some amount of paracetamol, that is around 12 gram or 16 gram on a single dose. So the patient will end up into grade 4 of encephalopathy that includes a comatose conditions. And in ABG, when we will have a acidosis of less than 7.3, a pH of less than 3 resulting into metabolic acidosis, prolonged PT-INR, and increased creatinine level, that is more than 3.3, and falling ALT and AST level with worsening prothrombin time. So these are the five indicators you will have a poor outcome. One is grade 4 or grade 3 hepatic encephalopathy or coma, and pH of less than 7.3, prolonged prothrombin time, increased creatinine values more than 3.3, and increased ALT or AST level with worsening of prothrombin time. Coming to the management part, if the presentation is within 8 hours, treatment of choice is activated charcoal, that is the dose should be 1 gram per kg body weight. We need to check care of glucose, the WBC count, the fasting blood count, renal panel, liver function test, ABG, and the serum. If the presentation is more than 8 hours till 24 hours and suspicious of large overdoses, they should not wait for anything. We need to start with the N-acetylcysteine, that is the antidote for paracetamols. We need to stop this if the level below therapeutic line and INR or LFTs are normal. If unknown time of overdoses is there, so we need to take care of these clinical signs, and as well as we need to treat in an early basis. We need to determine the serum acetaminophen levels and determine the INR and renal function on LFT levels. We need to treat with acetylcysteine if serum acetaminophen or transaminases like ALT, ASTs are in a very high form. We need to take care of these simple basic investigations like attending to the cardiac monitor, looking for the initial set of vitals, including your GCS, BP, heart rate, respiratory rate, saturation level. And we need to give some supportive treatment like somebody is having a low oxygen saturation level, we need to put him in oxygen. Somebody is having a low BP, we need to put him on crystalloids, correction of this acidosis part, and we need to give him more fluids, that is IV fluids, crystalloids, NS or RL. And we need to start with this N-acetylcysteines, that is the antidotes. If the person is having some serious issues with the N-acetylcysteine or it is having some cross reactions, then we can start with the methionine part. So what happens exactly with this alcohol? It absorbs up to the 60% of the toxic substances when the poison is swallowed, and it stops the poison from the leaving the stomach. So basically, it should be indicated when someone presented to emergency within 1 hour of injections. That is very important. The presentation should be within 1 hour so that the charcoal absorbs up to the 60% of the toxic substances. If less than 8 hours, we need to start with this unknown injections or there's some amount of injection is very high, then we can start with this activated charcoal. The dose is 1 gram per kg body weight. Then two treatments methods. One is activated charcoal, works by absorbing the unabsorbed drug in the stomach. Second one is by N-acetylcysteine. It works by increasing the hepatic glutathione stores. If 8 to 24 hours and suspicious of large overdose, then even we need to start with this N-acetylcysteine. It protects the liver in many forms. So it is available both in oral and IV form. This is the antidote of choice. For the oral form, the loading dose is 140 mg per kg, and we need to give a maintenance dose of 70 mg per kg every 4 hours for next 17 doses. And if you are giving by IV form, the loading dose is 150 mg per kg, and we need to give it 5% dextrose over 15 minutes, followed by a maintenance dose of 50 mg per kg in 500 ml of dextrose over 4 hours, then 100 mg per kg for 16 hours in 1 liter of 5% dextrose. The dose should be remembered very thoroughly because once the patient land up into this grade 2 or grade 3, it is very difficult to revive the patient or for the survival of the liver. What are the side effects of N-acetylcysteine? Basically, it is having rash, that is some anaphylactic reactions. So treatment with the chlorpheniramine, Abil, observe, and sometimes it may require hydrocortisone and IV fluids. And if somebody is having nausea, vomiting, and epigastric discomfort, we may give some antacids, like including H2 blockers or PPIs and antiemetics. Okay. So when the patient is known to be sensitized or having like allergic to N-acetylcysteine, we may give methionine. The dose should be, for oral dose it is 2.5 gram for 4 hours, and we need to continue it total for 10 grams till 16 hours. So dose should be remembered 2.5 gram per hour for 4 hours and continue for next 16 hours. The ongoing management, Blood investigation on the next day, we need to regularly check with the INR values. If the PT is very high, we need to continue with the N-acetylcysteine. We should not forget to send renal profile and liver function test, including a coagulation profile for the every patient who is having a history of paracetamol overdose. Ultimately, this liver transplantations is a life-saving, but in this era, it is really a challenge to get a donor for this liver transplant. And before I conclude my slides, I need to have this last one. Patients should not take 4 grams of acetaminophen per day. This is a education kind of stuff. The threshold may be lower for patients with liver disease or cirrhosis. So we need to ask them to take the paracetamol as low doses as they can. If they are able to bear the pain, we may ask them to take 650 mg only twice or thrice maximum if the pain is very severe. Because it increases the risk of hepatotoxicity with chronic alcohol use. The person should be very, very thorough while taking these paracetamol tablets, because that low doses up to 2 gram, if sometimes that can lead into liver toxicity. Patients should be careful when taking numerous products containing acetaminophen, because it is easily available over the counter medications. Thank you for patient listening. And this is my reference I have taken from this Oxford Handbook of Clinical Medicines, and I have searched from this internet guidelines. Thank you so much for patient listening.